Hello, I'm Training Officer Scotty Davis with the Paducah Police Department. The training that we're doing today is a tactical medical refresher. Kentucky League of Cities has it as an annual viewing recommended by the law enforcement consultants. The instructor today will be Dr. Irvin Smith, who will be assisted by Jared Woodruff, who is with the Paducah Police Department SWAT team and is also an EMT.
Hello, I'm Irv Smith. I'm the Medical Director for Mercy Regional EMS here in Paducah. We're coming from our EMS classroom today where we teach EMTs and paramedics. What we're going to do today, we're going to review some skills in CPR and tactical emergency casualty care. The American Heart Association tells us that there's a very important chain of survival for a patient who has experienced an out-of-hospital cardiac arrest. And two of those skills that are most important are as good, effective, continuous CPR and the early use of an automatic defibrillator. And those skills are in the realm of care for law enforcement officers. Since 2010, we have taught a program for law enforcement officers on tactical emergency casualty care. This is based on a teaching outline that is provided by the Tactical Emergency Casualty Care Committee. Now there's three basic things that we teach our law enforcement officers how to deal with in a tactical situation. We teach basic airway control with a nasal airway. We teach hemorrhage control with either wound packing or a tourniquet or direct pressure. And we teach how to take care of an open chest wound by covering that chest wound. So these skills we're going to demonstrate today in shorter video sections. The fate of an injured victim depends on the care that's provided by the first person that contacts them. This is the basic premise that we've learned from our colleagues in the military. Our current military has a program called Tactical Combat Casualty Care that has been used since the post-Vietnam era. The lessons learned by our military have been transferred to our world on the street by the Tactical Emergency Casualty Care Committee. So we're going to show you some of those skills now. For the patient that has an out-of-hospital cardiac arrest, the two factors that are critical to their survival is early CPR and early defibrillation. Those are two skills that can be provided by law enforcement officers. When we find a victim down, we want to rapidly assess them to see if they're breathing or moving normally. We don't take a lot of time checking for a pulse. If a victim is not breathing or moving normally, they need chest compressions. Those chest compressions are delivered at a rate of 30 compressions and then 2 ventilations. And those compressions need to be hard and fast at a rate of at least 110 per minute. And each time we come off the chest, we want to make sure there's no pressure on the chest so the chest gets a full recoil. As soon as an AED is available, the AED needs to be turned on, pads placed on the chest, the AED allowed to analyze looking for a shockable rhythm. And that shock needs to be delivered as soon as possible. And then immediately after the shock is delivered, we're back on the chest doing at least 2 minutes of CPR before we do a pulse check. These factors are critically important for survival of an out-of-hospital cardiac arrest. If the victim is a police officer with a vest on, that vest has to be removed and you've got to get your hands directly on the chest in order for CPR to be effective. In tactical emergency casualty care, there are three basic skills that we focus on. Those are skills that help us with airway management, with bleeding control, and with closing an open chest wound. What we're going to demonstrate here is a placement of a nasal airway. There are several different airways that we could use, but for our law enforcement officers, our primary airway we use is a nasal trumpet. The nasal trumpet is carried in most of the IFAC kits. Most of them carry a size 28 to 32 French nasal airway. The nasal airway is sized from measuring from the nose to the tip of the ear. The nasal airway is lubricated with some surgical lubricant before it's placed in the nose. We take a look at the nostrils and we want to choose the largest nostril. Sometimes that's the right, sometimes it's the left. When we insert the nasal airway, we always want to go bevel towards the nasal septum. And we just use gentle pressure and this drops right into place. The nasal airway fits behind the tongue and gives us a nice open airway passage. If we want to choose the left nostril, remember we're always going to go, the bevel points toward the septum, so we'll start off with it in this direction, and once we get it inserted just a little bit, we'll rotate it and the nasal airway drops right in. The other thing we do for airway management, once the nasal airway is in place, we're going to put the victim in the universal recovery position. And this is on their left or right side with their lower arm under their head. This keeps their spine in a neutral position and will allow any blood or secretions to come out of the airway by gravity, and will let the tongue fall forward. So for tactical emergency casualty care, for airway management, we're going to use the nasal airway and we're going to use the universal recovery position, turning the victim on their side. In patients who have penetrating trauma, the number one killer is bleeding. So bleeding control is critical in tactical emergency casualty care. One of the first tools we're going to deploy on a bleeding patient from an extremity is a tourniquet. In this segment, we're going to use the CAT tourniquet, which is one of the brands of tourniquets that's commonly used in the field. So when do we place a tourniquet? Well, we're going to have law enforcement officers place a tourniquet anytime they have life-threatening bleeding from the extremities. Life-threatening bleeding is identified by somebody who's bleeding so much that there's a little voice in your back of your head that says, "Oh my God, this is a lot of blood." So when you place a tourniquet, you want to place it on the arm or the leg as high up as you can get it. You place it over clothing and use the windlass mechanism to cinch it down to where there's no further bleeding or there's no distal pulse. One of the problems with tourniquet application is not putting the tourniquet on tight enough to actually control the bleeding. So the tourniquet goes up as high on the extremity as you can get it, and you cinch down the windlass until there's no bleeding or there's no pulse. On this CAT tourniquet, there's a little white strip there where you can put the time the tourniquet was applied. If that's not there, or you're using another brand of tourniquet, you can just write that time on the patient's forehead with a marker. When the patient gets moved to a casualty collection point and they get to some more medical resources, EMTs or paramedics, that patient's going to be evaluated, and it might be that wound can be packed and then the tourniquet can be removed. That's called a tourniquet downgrade. It does not mean that the tourniquet should not have been placed initially. Remember, we're asking our law enforcement officers, when they see a patient with heavy bleeding from an extremity and they're in a high threat or high risk situation, we want to go ahead and get that tourniquet on and get that bleeding stopped, because every drop of blood is precious. Now, the second tool we have to control bleeding are pressure dressings. There's several different pressure dressings on the market. This is one called an Olace, O-L-A-E-S. Olace was an Israeli paramedic who this dressing is named after. It has an elastic band on it to provide compression. It has packing material that can be pulled out to pack the wound with, and it also has a sheet of plastic that we'll use in a moment to show you how to cover a chest wound. Now, this is just one of many kinds of compression dressings. Most bleeding will stop with direct pressure, okay? So Woody's going to place this dressing for us on this victim's arm and show you how to put the Olace dressing on. I'll hold this for you. Now, that little plastic cup on top puts a little bit more direct pressure down on a wound. So when we come across that plastic cup, that actually applies more direct pressure to the bleeding wound. And the O-lace has a nice clip on the end of it that lets us quickly snap that clip into place and to keep the dressing secured. We can usually stop bleeding on extremity very easily with a tourniquet or compression dressing. A problematic area is what we call junctional wounds. Junctional wounds are wounds in the groin, in the axilla, or in the neck. That's a location where we can't get a tourniquet above it. In that situation, the treatment for the bleeding is to pack the wound. On the market today, there are several different types of hemostatic agents. What I have in my hand here are 2 samples of Quick Clot. Quick Clot is a product that's got a chemical impregnated into the bandaging material that aids in blood clotting. There are several other products on the market. And these products are packed into the wound, and the pressure dressing is put over the wound. Again, those are for junctional hemorrhages, wounds in the groin, in the axilla, and the neck. But the key is in any bleeding patient to get the bleeding stopped. The third injury that the Tactical Emergency Casualty Care course stresses how to take care of is an open chest wound. For the purposes of this course, we talk about the chest being from the nipple line to the belly button. So any wound we find in this area, front, back, or side, we want to cover that. Because if there's a hole in the chest that communicates with the lung cavity, air is going to preferentially go in that hole and not enter our airways, not enter our lungs. The O-lace bandage comes with a small sheet of plastic that can be used to cover a chest wound. The quickest way to cover an open chest wound is with your gloved hand. But the O-lace has a sheet of plastic to be used to cover the chest wound, and there are some commercial chest dressings that can be purchased. This is called the Asherman Chest Seal. There are many different commercial products that can be used. But one of the things we have on medical scenes, we usually have a lot of plastic. Again, the O-lace comes with a sheet of plastic in it. That's one of the advantages of carrying the O-lace dressing. But we want to seal that chest wound. And once that chest wound is sealed, we want to be aware that we might have a situation develop called a tension pneumothorax. And that's where air builds up under pressure in the chest, and the victim may have more trouble breathing, and then we want to burp that dressing and let the air come out that's under pressure in the lung. But sealing an open chest wound is one of the critical steps in tactical emergency casualty care. This is an example of one of the individual officers' first aid kits that's carried by the Paducah Police Department. Inside the kit, you see that the things that we showed you when we're doing the segments. This is a cat tourniquet. This is a Celox gauze, which is one of the different hemostatic agents for wound packing. We have the nasal airway, O-lace bandage, and a pair of bandage scissors and some surgical lubricant for the airway. If you need more information on these topics, the organizations to contact for CPR would be probably your local hospitals, or you can contact the American Heart Association directly. The best resource for tactical emergency casualty care is going to the website www.c-tecc.org, and this will hook you up with the Tactical Emergency Casualty Care website. This website has all the information that will allow you to customize a program for your agency.